Good morning and welcome to this webinar where we will discuss the long-term impact of remote therapy. Welcome back to those of you that joined us last time for defining a new landscape. We're now at a very poignant stage of this journey. We're 1 year on. We had a minute's silence yesterday and the candles were in the window yesterday evening. So we're at a stage now where we can look back with some reflection. Unlike a year ago, we've got many resources that we can draw on now to help us through. We're grateful for you joining us today and taking the decision to join us on this webinar. We'll hope you'll find what we have to say interesting and helpful. For those of you that don't know me, my name's Glen Whitehead. I'm a solicitor here in the serious injury team at Sheffield at Irwin Mitchell, and joining me is Susan Pattison of SP Therapy Services. It's fantastic that we can welcome Susan again to join us. It's a real opportunity for us to discuss with someone who's living this as a business and a therapy provider on a day-to-day basis. So it's really a chance for us to take stock, gain a bit of insight into how others are experiencing this journey and the challenges that we've faced over the last 12 months. We're going to approach today in three sessions or three sections. I've used a bit of analogy of building a raft. Bear with me for that. I know that analogies and metaphors have been used quite a lot over the last 12 months, but I hope you'll agree that this one fits well. We'll look at the three periods that I've set out on the slide there. There will be Slido questions involved today as well, which will bring a little bit of interactivity to the webinar. So please do open up Slido in one of your browsers now. If you just put slido.com, #therapy to join there. The webinar is recorded, so you will have the opportunity to review it back after the event. And also, if you could put on any questions into the questions and answers section, if you could put your name or contact details on there, we'll be able to get in touch with you if we don't manage to address them immediately in the course of the webinar. So if we can move on to the points of view, or as I said earlier, Susan has a physiotherapy and rehabilitation business. I'm a solicitor. I was formerly a physiotherapist. There is a physiotherapy slant on what we're going to be discussing today. But I think we established in the last webinar that digital services and remote therapy are not new. They have been used, but what the pandemic presented us with was a completely new problem. It removed the option of face-to-face last year. Since that time, we've got the opportunity to look back over certain surveys. We're going to be looking at the CSP study that was done or is continuing to be done. Also, your respective professions, if you're not a physiotherapist, have also been looking at this in detail. There are lots of webinars out there and guidance sheets, and I've just put a few of the options on the slide there. So I'm hoping that although our point of view today may have a physiotherapy bias or slant, there will be lots of issues here and lots of discussion points that will be relevant to your profession, and hopefully we can bring all those views together and have a good look at what the long-term impact of remote therapy will be. So as I said, the effects of remote therapy, or the need to provide remote therapy, had a specific impact on physiotherapy because we usually provide hands-on treatment. And as I say, the effect of the perspectives and the views on that have changed over the last year. We at Irwin Mitchell are very much rehab focused. It forms a big part of what we do with our clients. And as we progress through these slides, hopefully we can use the opportunity to interact and get your views too. Now, if we move on to the first of the Slido questions, this is a very easy one to start with. Where are you? We know that up and down the country there were different restrictions imposed as we went through this journey, and so what I'd like you to do is just answer that question, respond as to where you are in the country, and then we can get an idea of where we are and far and wide the effect that these changes had. What I'll do to start with is recap over the first part of if we can go to next slide, please, Tasha. We're going to look at the first period of lockdown and the effects that it had. So there was a bit of a flat spin where we had to look at the options available. From our point of view, the contact with the rehabilitation providers was very much a how do we cope with this, and we looked at this in detail during our first webinar last year. The guidance from professional bodies was minimal, and it very much relied upon us having to liaise with the rehabilitation providers and find our way forwards. There was a lot of uncertainty, which created this panic mode almost. This, how do we deal with this? And like I say, it was a case of building a raft. How do we get through this? How do we move forwards? There was questions about funding. So whether defendants, insurers, if there was a joint instruction, whether agreed packages could be continued. Was remote therapy going to be considered proper therapy? Did the normal fees still apply? All of these questions were presented. At the forefront of that also were the questions posed by our clients. Lots of our clients relied on the routine, the structure, the confidence that they had in the rehabilitation program. And was the remote therapy provision going to change that in any way? So we were there to reassure our clients, while at the same time trying to establish how we were all going to move forward and create this new form of therapy and treatment. So, as I said before, we moved on and we created this raft, and the options for remote therapy were discussed. As you'll remember, there'll be a lot of names on there that were unfamiliar a year ago, but are very familiar now, and the options now are far and wide. Back then, there was initial concerns about the security of some of these options and how suitable they were to provide those remote therapy. However, we went forwards, we put these packages together, and the CSP survey that was carried out gives us some response on how well we did that. So as we can see there, almost all of the services that responded to the CSP survey were providing remote therapy services. However, it was a very makeshift approach. Nearly half of them had no real service specification. It was ad hoc on the wing. And the development and presentation of those remote services was very much a let's deal with this, a fight or flight response to the challenge. At that time, most people almost scaled back what they were doing and used the telephone triage option. So the service, the scope of service that they were providing had to be drawn back a little bit to enable them to be able to do it effectively. Face-to-face treatment was stopped completely, so this was the only contact they were able to continue with their client base. A lot of the development of these remote therapy services was carried out without any interaction with the client. So it wasn't a case of what do you want, let's put in place what you might need. It was a case of let's get together something that we can present and put forward, and then hopefully we can start to work with that once it's in place. So it was this immediate response. It was very much providing a makeshift raft, and over half of the physiotherapists that responded to that survey experienced challenges in doing so. So what I want to ask you is, how did you respond to the challenges? What was your chosen approach? So if you can respond on the Slido now and tell us exactly how you took the first steps in that journey, that would be great. And I'm going to hand over to Susan, who's going to tell us exactly what she did. Thank you, Susan.
I think I need a good morning. Good morning, my name's Susan Pattison, and I am from SP Therapy Services, and I'm a chartered physiotherapist, but I also have occupational therapists in our team. So it is a physiotherapy bias that I'm presenting this morning, and it is a bias towards our choices and our decisions. And I think our choices and our decisions were dependent on the makeup of our particular business at the point in time that lockdown was announced. And just because we went in one way didn't mean it was particularly the right way. It was the choices that we made at that time, and our journey is probably going to be very different to other people's journey. I think significantly we were community based. So in being community based, our therapists were working remotely anyway. They all had access to business phones, they all had access to business laptop devices complete with a webcam. So I think whilst other businesses were scrambling with it to actually get the physical technology, we didn't have that scramble, which was fortunate because of the nature of our business. The second thing that I'm going to point out to you is our geography, because I think certainly as the pandemic went on, we were less than fortunate, and this again impacted on our choices and our decisions as things went forward. And this was one of the major reasons why Glen and I wanted to know where you were, so that we could understand your experiences also. What I'm going to do now is, what Glen talked about building the Raft. I think the thing is when you talk about remote therapy, it in itself has no definition. It has no definition. And one of the things we were really keen as a team was, if we were going to do this, was to take ownership of the definition as to what remote therapy meant, what it meant for us, what we would be proud to deliver, what we felt would actually give us a sense of ownership of what was going on. And we discussed this very heavily as a team. It was not triage. We wanted to not trim back our services. We wanted to try and deliver as high a quality services was possible with the restrictions we were facing. And so the three words that we began to talk about in terms of delivering remote therapy is, it had to be safe, it had to be meaningful, and it had to be realistic. So this graph here is a graph of the hours, that we put in order to make safe, meaningful and realistic the sessions that we had. And you can see that the spike was really high in the beginning, and the hours that we put in that were non-chargeable were massive, and this continued until we were satisfied that we were secure in what we understood by safe, meaningful and realistic, and this took until September. I've just had a message. Can I just confirm that everybody can hear me okay? Okay, can we move on please? Thank you. So I think when Glen shared his slides with me, I had a little chuckle at the choice of the image that he had of a gentleman in a suit on a beach with his sunglasses on, looking at a laptop. And I loved his analogy of the raft, but I remember what the raft was like for us. And I think it was quite a tough journey, because I think the reality is that we were not learning to sit at a desk. Anybody who knows a physiotherapist knows that they are very unhappy sitting at a desk. And actually to deliver therapy that's safe, meaningful and remote and realistic meant we weren't going to sit at a desk. We spent a lot of time working out angles. How could you actually see a physiotherapist? How far away did she have to be from what was going on? What position did the camera have to be in? And so I think the thing is, even though I said to you a bit in the beginning, we actually had the available resources or the branches to make the raft. And I was certainly confident within my team that we had the creativity to design the raft. The reality was that we were in the same boat as everybody else. And this picture is not a Shutterstock image. It's actually one of our therapist husbands is a very talented photographer, and he constructed this image of Anna working on a stool with the laptop on the floor with the children around it to illustrate the challenges of what the reality of what remote therapy was for us in those early days. Thank you. So I talked extensively last time about what we learned in lockdown 1. And as we came to the end of lockdown 1, we certainly had a crash course in technology. I think we all had that. There was this expectation we were supposed to be masters at Zoom and Teams, and we weren't. We had a crash course. We certainly eliminated all of our preconceptions. I think we all went into this with preconceptions that it couldn't be done, that younger people would deal with this better than older people. We learned in lockdown 1 how much we valued our handling skills, and we became more reflective in how we should use them. And we also realised that we needed to take a greater responsibility of handing over the ownership to promote health and wellbeing to the people that we were working with. and we really reflected that maybe we needed to do that better. We came out of lockdown 1 with a tool in our box. We came away with improved relationships, I think, with those families that we had worked with. We understood that we needed preparation time to direct the outcomes in the right way. We didn't always need to be in the room. And we realised that we had a very effective teaching tool and somewhere by which we could check in on confidence and competence of support workers. And one of the phrases that one of my team actually coined was, we could be there without being there. And sometimes the withdrawal in order to support ownership is something that we really need to work on to be better at. So I summarise lockdown 1 as to do it, you needed to have courage, you needed to be versatile, and you needed creativity, and you needed commitment. As I said on that graph, it took us from February, we started in February before the lockdown started to look at the problem. It took us till September until we could actually say, yes, this was something that we were comfortable with. And we just employed the mantra, stop, think, plan, do. Everything we did, we stopped and we thought, is this possible? How are we going to make it happen? And then we went back. I think the most important thing for those people who are still struggling with the idea of remote therapy is just to accept it as different. And our conclusion at the end of last time I spoke to you was that it was possible to do remote therapy, but it was not necessarily preferable. And that what we had experienced was in the context of a unique experience, and we were looking forward to the opportunity to seeing what life was like on the other side. And so we came out of lockdown 1, we'd missed people. We're people as physiotherapists. We'd missed using our hands. Our patients were asking us, when can you come back? I miss what you do. This has been good. It's been great that you've done this for me, but I really am looking forward to seeing you. Because the difference we make is a very human one, and the therapeutic touch, or the ability to have contact with people, a physical contact people, is something I think that we've all missed over these 12 months. When it's your major tool as a physiotherapist, it was quite a difficult challenge. Thank you.
Glen, you're on mute.
Yep, just thank you for that, Susan. That was really helpful. I think many of you will be able to relate to much of what Susan said there. I just want to skip back, if we can, Natasha, just to the geographical variation of the audience today, just so that we can look at the first Slido question. If we can just take a look, as we see there, a lot from Northwest. If we can scroll down and just see the others. Okay, so a huge number there, majority from the northwest of the country, which is really helpful, with it being Susan's area as well. If we can go on to Slido 2, just onto the question, and this was really reassuring here, just to look at how many of you took steps, prepared systems to provide remote treatments. And I guess that's reflective of the audience today here. You're all here, you're all very proactive in this, and wanted certainly to take hold of the issue with both hands. So that's really promising to see. Okay, let's move on into that sort of interim period. I've put lockdown 2 here, and we're going to discuss the regional variations. So as national restrictions eased, I think the CSP permitted face-to-face contact from the end of May. We were getting into the situation where hairdressers were opening at the beginning of July. We had Eat Out to Help Out, and there was very much a sort of gradual encouragement of return towards normal. I won't say turn to normal. It was that sort of vision of new normal. But at the same time, while all this sort of opportunity and return was being encouraged, we had these local pockets of spikes of the virus emerging. So Leicester entered a local lockdown, and that was closely followed by Manchester. It was then clear that this certainly wasn't over by any means. We were needing to deal with this on a more long-term basis, and the tier system was introduced. There was restricted travel between tiers, and this created almost a conflict. From our perspective, we were getting a lot of people asking us whether it was permissible to travel across those borders for treatment. And although the concessions did exist there was that internal conflict with what they were seeing on the telly with what we were asking them to do. So this permission to be able to pass over those borders, the ability to travel, and in being in Sheffield, we were dealing with people in Manchester who were on their own local lockdown. We were dealing with people in York who were on a lower tier, so up to the north and northeast of our region. There were tier 2 and lesser restrictions. So there was a lot of different levels here that had to be taken into account. When face-to-face contacts were reintroduced, next slide, please, Natasha. There was a lot of PPE involved. There was a lot of risk assessments risk assessments on a level that we'd never seen before. And this hybrid approach was introduced, but in the background, the remote therapy continued. It wasn't a case of this remote therapy provision disappeared. It was very much still part of what we were doing. And Susan graph earlier on showed that was the case. What did change is the way in which we were approaching this. So rather than setting up the service without any collaboration or communication with the clients, the CSP survey tells us that when we'd reached this stage, 65% of us were seeking feedback from clients. Unfortunately, at that stage, only 31 were seeking feedback from staff. So we did have this situation where some people were having negative experiences as providers, but those weren't being looked at. But at least at this stage, the clients were being responded to and the development was taking place. The platforms of choice, 59% was still on by telephone. This is again in response to the survey, and you'll notice there, because they clearly add up to more than 100, that this was multiple answers were permitted on this. But there was still, most people were providing this by telephone, and a lot of the internet platforms were also being used in order to get the message and the remote treatment out there. So even though the face-to-face resumed, remote therapy was definitely showing us that it was here to stay. So what I'd like to ask you now on Slido is what was your approach? So during that period when local lockdowns were taking place, there was a regional approach. There was this uncertainty of whether we could or couldn't with our face-to-face. What were you doing? And which of these statements on Slido there best provides a description of your approach to that period of time? While you're answering that question, Susan again is going to tell us exactly how she approached it during that period of time. Thank you, Susan.
It's nice to know I'm sharing my experience today with fellow Northwest therapists and case managers and folk, because I think it has been a very different experience all the way across the country. So I hope you can relate to some of the things that I am going to say. We had our risk assessments prepared, we had boots full of PPE, we were ready. We had a planned and a phased return going from essential through to preferable, and we had a planned return that was going to be eased in, and we felt very, very positive about returning back to our patients. The reality started to look a little bit more different quite quickly for us in the Northwest. So what we found was, as we started to go out, is that because COVID was still prevalent within our communities, whilst I'm sure you've all experienced this, our diary management suddenly became the week that you had set out was not the week that happened. The child that you were going to go and visit, if they were back at school, their classroom was closed, or the contact had been made to say that there was, by test and trace, to say you couldn't go and see that patient. So the thing was, having the robust tool in our back pocket of remote therapy meant that we could very quickly and very dynamically swap between the two. I think the other thing that happened was that, as excited as we were to get back out there and work with our patients, suddenly the experience of working in gloves and aprons and pinnies did not present itself quite as positively as it had on the other side of the fence when we were all experiencing Zoom fatigue. We all felt a great amount of guilt for complaining about what PPE was doing to us when we knew our colleagues in intensive care were really struggling. But the reality of trying to deliver therapy the way we used to did not exist. So we started to actually sit back and actually question whether there was almost a utopia of the idea of going back to straight hands-on. And so we started to look at remote therapy in a slightly different way going forward. So I'm sure, because I'm speaking to people in the Northwest, that this probably mirrors your own experiences. This graph is our journey in terms of contacts. So blue contacts are face-to-face, orange contacts are remote therapy. So you can see the arrows at the bottom indicate at lockdown 1, when the CSP's instruction to us in private practice was virtual only, that we flicked very quickly to remote. And you can see as the guidelines from the CSP actually said that we could open from face-to-face business, we slowly and progressively started to move forwards. Unfortunately, very quickly woke up one morning to find out that we had local restrictions. And you can see that that pattern really has continued, and actually the national restrictions have not actually had as bigger impact, because we never really came out of the local restrictions. So there was a real marked difference between what we were allowed to do. For example, the CSP said you can go back to with confidence to providing face-to-face sessions, to what our patients were comfortable with, because the confidence was not with them to open their doors to us. So there's a difference, isn't it, and a dichotomy between being possible and preferable. The dichotomy was the other way. It was possible for us to provide face-to-face sessions, but our patients were not always considering that that was preferable option for them. So this is our pattern, and I'm sure you can relate to that. So 1 year on, it is still a very necessary tool in our box. It is something that we have become really quite skilled at. It is something that we can flip dynamically between different things. And that is what the easing of the restrictions and the local lockdowns has taught us. I think as we came out of lockdown 1, it was like, well, yeah, OK, well, we survived that. We've learned something. Let's crack on with our day jobs. Whereas now we're really looking at it and going, no, this is something that we really have got something to offer. And we need to actually, as a team, step back and understand more in terms of how it fits into going forwards. We are still finding, even at this, coming now, that the confidence to re-engage is less, and a lot of people are actually deciding that they are going to postpone actually engaging with us because of the vaccine coming along. So we are finding now that what you need in terms of being a therapy team is you need flexibility. You need to be constantly and dynamically risk assessing the problem in front of you. And what we've all had to develop over the year is stamina, and that's the stamina to keep going with the constant cognitive demands that are coming with the associated risk assessments. Acknowledging that our team were established and experienced therapists, that actually pushing them out of their comfort zone was beginning to become tiring. But what we have reflected on is that there is a lot of push from the CSP to actually understand what's going on, and that's fantastic because we've got to learn from this. But we are very conscious that the decisions we are making still are not rehabilitation choices. The decisions we are making are still being influenced by the changing pandemic that is underneath us. Thank you.
Thank you, Susan. Just coming on to the Slido response there, you can see that the majority of you out there, 85%, have told us that you did take a hybrid approach of face-to-face and remote, which is great to see, and also reflective, I think, of what's seen across certainly physiotherapy, and I suggest across many of your other allied health professions as well. Some still there not doing the face-to-face treatment, so 11% there, but remote therapy provided, and still a very small percentage there. Still some saying, well, look, we're in the middle of a pandemic, we're not able to provide face-to-face or remote treatment for whatever reasons they may be. So still there we can see that 4% of you are very much impacted by the pandemic and the challenges that it's presenting, and not enabling you really to do face-to-face or remote therapy. So what are we going to do now is move on to the next stage, we were all looking forward to a normal Christmas as possible, as if you remember rightly. And what we started to see was this repeat wave. So as we entered the autumn and winter months, we had another wave of the pandemic. But this time it was different. So we have the established methods, the established practice of remote therapy in the toolbox. We have that there. We have an acceptance of remote approach, both across the therapies, across your services, but also from the clients, and also within our legal sector as well. It was less of a surprise. It was less of a, okay, how is this going to be accepted? We were well down the path. So as these new restrictions were brought in, it was, here we go again, don't worry, we've got this, we've done it already. There were also questions raised of, is this how it's going to be in the future? You know, is this how it is going to be for the long-term plan? Is this the NHS's long-term digital care approach to health? Is this what we will all be doing? And this reflection and analysis is really, again, what the CSP study started to look at as well, the study with the University of Manchester. What are going to be the long-term effects of this? Is this going to be a permanent tool in the box? And if so, how are we going to evidence that? The treatment that everyone provides and that you all provide as practitioners needs to be evidence-based. It needs to be reviewed. It needs to be developed. It needs to be rather than an emergency life ring or a Raft, it needs to be something more established that we can base our practice on. Now, in addition to the original survey, what the study also looked at was a literature review. It also looked at a number of case studies, and you can find those on the CSP site. There were many submitted. Susan herself submitted one that's on there. So you can see how these were started to be gathered and looked at to look at the bigger picture. Now, what those results of the literature reviews and case studies showed that the responses were very similar to the original survey back last summer. Very much a mixed picture, very much a, yes, we can do this, but there are these challenges also to be considered. And what they identified was a large evidential gap. So there needs to be this support for the way in which we're going to do this if this is going to become an established tool in the box. So I won't go through these one by one, but these were some of the responses that were made to that survey. And you can see there's a mix there from being very positive and saying, yep, this is great, we're getting some great feedback here from the clients, to really some ones where the people were finding it very difficult. And that one statement there is from a practitioner who found it isolated, but also some clients were missing that human touch that Susan referred to earlier on. So there were some key components here that the long-term impact was showing us. There were some negative effects of having to do this, and therefore there is a reason to keep looking at this, to refine it, to make it a better approach. From our perspective, the clients were very grateful that they were able to continue with their rehabilitation, but also there were questions over whether it was going to lengthen their period of rehabilitation. Were they going to achieve what they were hoping to achieve set out in those early goal plans and objective setting sessions? So what I've done here on this slide is just try to draw together those benefits. You can see, again, I won't go through them line by line, but on the one hand, the remote therapy provision created this option for us to turn to. When people are isolating or people are lockdowns introduced, it gives us this go-to solution that we can use. Some people mentioned that it's got benefits with regards to time, and hopefully the organisation, the opportunity to have them fit those sessions into the day makes it efficient. The novel, fun and motivating factor certainly was apparent in the early stages. Whether that's still there is questionable, but also the challenges there are very, very real. We've seen the big campaign about laptops for school kids over the last few months, but this was very real for clients as well. If they haven't got the technology, they haven't got the hardware there to access this remote therapy, then that creates an immediate challenge for them. The confidence or the familiarity with the online platforms is also a barrier, and this is a very real concern. If we can't get that method or treatment into their room, then you have that immediate barrier. From a practitioner's point of view, the loss of the reflection time, the need to switch from one to the other very, very quickly, doesn't give you that time to wind down from one, think about what's happened, reflect on what's happened, and then move on to the next one. It's this constant switching. And also the Zoom fatigue that Susan mentioned earlier on, the impact of having to be screen ready all the time, the fatigue, cognitive fatigue, the visual fatigue that we're all experiencing. So on both sides of the coin, there were some benefits and challenges. So what I want to do is now explore your views on the future of remote therapy. So these benefits and challenges, how have they affected you? How do you feel things panning out? How do you see the tool in the box for you? What do you consider the long-term impact of remote therapy on your practice? So if you can turn to Slido again and respond to that, we can now turn to Susan again to hear her view for the future. Thank you, Susan.
Thank you. It's great to see that so many of the practitioners in the Northwest made the same decision. I've always thought we were a very dynamic set up here. So what I'm going to do now is go through some of the learnings that we have reflected on as a team and how we're taking this forward. I'm going to start with the negatives. You know, nobody's going to suggest that remote therapy can do everything. But some of the negatives in themselves turned out to be positive. I mean, what we learned was that although we thought communicating via a screen was difficult, actually PPE was equally as difficult and continues to be difficult. And I think we're all reflecting as a team, as much as Boris has suggested that we might be back to normal in June, I can't see in healthcare that things like being able to take our masks off is going to be a possibility. And this is going to be something that we're going to have to think of going forward. I think the novelty factor has dwindled. I don't think this is actually to do with remote therapy. I think we're all dwindling, we're all fading, we're all getting tired. And I think it is a nature of the longevity of what's going on. We found in the early days that it was quite easy once we got our act together to schedule the appointments. Because everything was remote. We're now finding that as life becomes allegedly, well, this blended approach is that, you know, things like MDTs being called, we're not desk people, we have got this blended approach. So actually managing between the two phases is difficult. One or the other is easy, but a blended approach is difficult to manage, and that is something we've taken on board as a team. In a crisis, I think if we managed to maintain our patients, which was our primary outcome, that was being considered as a really good outcome. But we're beginning to see now the longer term consequences, and I'm reluctant to hang that on remote therapy, because I think particularly I can only talk about the efforts from my team and the commitment to build meaningful and realistic therapy sessions. But there are other things outside, because of the longevity of this has been going on, that are beginning to impact. And we are seeing the long-term impacts of isolations and restrictions. We are seeing social anxiety with regards to our patients in terms of having contact with us. You know, social anxiety also in terms of now we're talking to them about, you know, what do you think about going back to the gym? And these decisions are still being impacted on. And we're also seeing a lot of deconditioning. So we're seeing that, I think we're all feeling it, aren't we? We're just not physically doing as much as we were before. So your therapist could be working really, really hard in the session, but there are external factors. So I think if we're actually looking at remote therapy and saying, does it work? I think we have to be very mindful of the context in which therapy is being delivered at the moment. And whilst I would put these down as negatives, I think that some of the biggest negatives have been the biggest learning curves for us. So I'm going to illustrate what I mean by an example, and anyone who was with me on the journey last time, I introduced a gentleman who we looked after in a nursing home, and it was our top story. I mean, the maintenance man was brilliant. They took the iPad, we'd spoken to the case manager had got an iPad. The maintenance man had unpacked it, set it up, asked the patient what he wanted, why he was doing it. Is this to talk to your family? No, it's to do my physio. And the maintenance man turned up every session, helped and support the patient to do that. And he was one of our success stories. He is an elderly gentleman. What happened in his nursing home is he has 3 successive lockdowns of the nursing home where he was completely isolated to his room. So it wasn't what, again, going back to what I was saying about, it's not just what we can achieve inside the session. Physiotherapy has also always been beyond the therapy session. It's how we empower people to move outside of the physiotherapy session. So it's very much been the longer term impact has been about the fact that he's been constrained to his room. And we're also seeing with him that because we are seeing that cognitively he's repeating himself more. I'm sure I'm repeating myself more because I've just got nothing more interesting to say because my days are quite similar. So whether that's a genuine problem on his part or again just an impact of the longer term things. And we have deemed that, well, despite the fact that this gentleman in our early days was one of our absolute, lighthouses of where therapy worked remotely, we have gone back to seeing him face to face because we feel that it's justified in this way. So if I now move on to the positive learning outcomes that we've definitely reflected on as a team, we can quickly move from one thing to another now. Our technical skill is high. We can change from one type of session to another. We've developed a baseline of resources to back us up. We have acknowledged that remote therapy session is very, very different, and therefore you need a different set of tools in order to deliver it. And I don't mean WhatsApp and a computer and things like that. I mean resources, videos of people moving from sitting to standing, or demonstration videos of different types of exercises, or demonstrations of perhaps an outcome measure. For example, if we're doing a timed up and go, that we can use those to introduce via screen share. But one of the big things that remote has taught us is just actually been outside of the therapy session. The big thing for our team is we are geographically spread out. We are community therapists. The collaboration that has happened between our team, the learning that has happened between our team, the problem solving that has happened between our team has been so much better. And if you're struggling with a particular patient with a particular problem, we can now pop in with our colleagues on a Zoom or a WhatsApp set to give that second opinion to help out. So I think remote has helped us out in many different ways other than the actual direct remote therapy with the patient, and we've certainly benefited from that. We have coined the phrase that being there without being there. And this is what we're asking ourselves at every stage at the moment, is that what is it I want to achieve in this therapy session? And do I need to be there? Or can I achieve that better? And I think it's really made us unpick the whole concept of what a therapy session is and what it is that we're actually trying to achieve. And I think this whole idea, isn't it, of ownership, of who's owning the therapy session and who is owning the responsibility for taking the therapy out of the therapy session in order to map it into daily life, is something we talk about a lot. And I think this idea of being there without being there, being able to pop in and say to a patient, so let's just have a look at your exercises this week, how are you doing, has given us much more flexibility that we wouldn't have had before. So I've got another example, a case study. Again, this was a case study that I used last time when I was talking, and I think the thing is there was an assumption in the early days that probably remote therapy would work quite well for those patients that were more able, but it would actually become more challenging if those patients were more disabled. I think it actually depends. I think we're again reflecting on why we've been able to be successful is that most of the patients we look after are case managed. They're well supported by fantastic support worker teams who are used to our engagement and involvement. They're used to taking the instructions from us and taking the responsibility for rehabilitation. This young girl is 8 and she's got profound physical difficulties. For those physios here, she would be on a GMFCS 5. So that means that she can't move any of her limbs. It means that she can't communicate. It means she's got poor head control and she actually struggles with chest infections. My problem when I met this little one was that she was treated like a China doll. And I had real difficulty getting the family to physically engage with her. They would care for her beautifully, but actually getting them to physically engage, I was just kind of breaking that barrier as the lockdown happened. I was really surprised when we sat down and talked and sat down via WhatsApp, obviously, about how we would manage physiotherapy through the lockdown. They said, no, we really need your help. We need your help. And this has been, again, one of our real successes, to the point now where they're reflecting to me now when I say, do you know, I really think I need to come out and have a look at this. And they go, no, don't come out, Sue, because if you come out, the problem is we will step back and let you crack on. And we recognise that our behaviour is different. And I think this is going back to this idea of ownership and empowerment about what's going to happen. So I do hope they let me back very soon, but they've had a rough ride. Let's have as a family, let's move forward. So I think the thing is that we started this by saying, you know, remote therapy is possible, but is it preferable? And I think the answer is it has to depend. It really depends. Our future at SP Therapy Service will be a patient approach, a blended approach, and we will be taking it patient by patient. We have very much all the way through consulted with our patient as to what they wanted, and we have very much taken their choices into it. And the blended approach has very much been driven by our patients who have actually said, yes, I would like to see you face to face, or no, I haven't got the confidence to see face. Can we go back to that remote? But for me, if you ask me to define what remote therapy is going forwards, I don't want to see remote therapy as, to me, it's just a choice of location, in the way that I would actually choose to either go and see a patient in a gym or a park. So it depends what I want out of the therapy session. So going forwards, I want to be able to actively choose remote therapy as a location that will actually drive a specific outcome for my patient, because I think there are those areas where remote therapy is preferable. But I also think I have to recognise that there are opportunities where remote therapy would not be as preferable. So to me, going forwards, I would like to see remote therapy be considered as a location. So for me, the other thing is I want remote therapy to move away from a lot of the discussions that have been going on about the technology. A lot of the things have been about, so which platform have you used? How do we meet these GDPR issues? I think as a profession, we are so far past that in terms of actually driving through constructive sessions, that I think as therapists, we've actually embraced the pros and cons of every single platform that's out there. I know the limitations of what is out there. And I think it's an environment, isn't it? And it's always my responsibility as a therapist to control the environment. It's always my responsibility to understand the pros and cons of the environment. So I think just accepting that it's a different environment is a way of moving forward rather than seeing it as something different. And for me, the success of the remote therapy is, again, not about the characteristics of the patient. It's not about age, it's or what their disability is, but it is about knowing that the task that you've got in front of you is actually appropriate to be done with regards to remote. I would not assess balance remotely, ever. I would always want to be in the room with somebody, but there may be other things that are appropriate. And I think Glen has touched on the fact that so many children had been disadvantaged during this pandemic by not having access to technology. Those silver surfers and those elderly patients are picking this up really, really well. So we don't need to prejudge what our patients do by their demographics. We need to actually do the remote therapy relative to the task that we want to deal with. And I think remote therapy, we've talked about it as a blended approach. It's another little tool in our box. And it needs to be time and context specific, because for me it's not the technology itself that is making the difference, but I've had the pleasure of sharing our experiences and talking to other therapists that are doing things very similarly. And what I've always been inspired by is the creativity, the versatility and the passion to just make this work for our patients. And it is the therapists, for me, who are the great problem solvers behind this that have actually made this work. Thank you. So that's my ramblings. So what does this mean for the future of neurophysiotherapy? Well, it's definitely the hot topic of the moment. it is the new kid on the block, and it is making us question our practice. And something that makes us question our practice is never a bad thing, as long as it doesn't turn out to be throwing the baby away with the bathwater. I am actively, as I'm sure most of you are, contributing to the information that's being evaluated by the CSP and in Manchester. There was a great straw poll, I don't know if any of you saw it, in the Neuro Rehab Times just recently, and it said that of neurophysiotherapists, 30% were waiting for it to go back to as it was before. 50% had accepted it has its place but needs more support to gain confidence, but 20% had actually embraced the challenge. And I think the thing is what I want to do is make sure that we define what is meant by remote therapy, because for me, triage via a telephone is definitely not remote therapy. For me, remote therapy is something that is safe, meaningful and realistic and works towards a therapeutic goal. Thank you. So if you ask me truthfully, what life will look like in the future, I'm probably going to stand on the fence and say, well, you know, my day-to-day goals are actually still being driven by the pandemic. My day-to-day decisions are still being driven by the pandemic. And I can't say hand on heart at this moment in time that my decisions about what I'm doing are solely being driven by the rehabilitation needs of the patient, but I certainly hope that will be able to come clearer. If Erwin Mitchell are kind enough to invite me back, maybe in a year's time with my ramblings, I'll be able to be clearer in what I'm actually saying. But we are still got to recognise that whilst remote therapy is established and part of us, we don't really know that it's full, what we can do with it on a day-to-day basis. But I think what we have to be mindful of is this old phrase, isn't it, is what I do know is the future matters on what we do today. And if, as the Slido indicates, that in the Northwest we have really been embracing this, then I think it's our responsibility to take ownership and actually define what remote therapy is, to make sure that we actually maintain our passion, our professional standards for changing things for the better, rather than things being driven by time and price. Because I'm sure others have found the same as us, is that this has taken an inordinate amount of time, and it's not necessarily a cheap option. And we need to be proud of our clinical decision making, because we took some extreme clinical decisions in an extreme situation when there wasn't any backup of any research, and history will dictate how that decision is interpreted in the future. So to me, it's all about making sure that we articulate, and I don't think sometimes we are very good at actually articulating the qualitative, sound clinical reasonings that we did in actually making these decisions. But I think as we come out of this pandemic and the choices become more about the rehabilitation goals and less about the choices related to infection, then I think we'll be able to take ownership of that more. Finally, yesterday was 1 year, and we've all been reflected, and I think I just wanted to say thank you. I wanted to say thank you for the patients who actually trusted us to come with us on this journey. I wanted to say thank you to the therapy colleagues for whom have shared this journey, not just in my team. There's been a fantastic group in the Northwest that have openly shared their experiences on a Facebook group, and I'm really grateful. And I also want to say thank you to the case managers and solicitors that actually put their trust and their backup into us to actually say, go out there and do it in this, because otherwise we wouldn't now have this tool in our box. Because I think I could have said hand on heart, if you'd have asked me to do this 12 months ago through choice, I probably wouldn't have done so. But I'm very, I don't know if grateful is the word to use in this context, but I'm very pleased that we now have this to go forward in order to offer a better rehabilitation for our patients in the future. Thank you.
Thanks, Susan. I mean, I think that summed it up really well, and probably a lot of what Susan was saying there resonated with a lot of you out there. The experiences that you've had, the conclusions that you've drawn to, and the questions that you're still asking yourself and others. And hopefully the opportunity today to hear Susan's case studies gives you that moment to pause, to look to one side and say, are you having this problem too? Are you having these challenges too? Because all too often it's very easy to carry on running ahead, trying to constantly cope with the everyday challenges without taking that moment and having the opportunity to sort of talk to each other and check that what you're experiencing is what everyone's experiencing. And I think that is the case, and it can be really helpful. Some of the comments that were put to the CSP survey were that practitioners were feeling isolated, and it's so important, as Susan said, with regards to the groups and support, and from our perspective, the constant communication with our rehab providers, that we can ensure that everyone's feeling very much that we're approaching this as a team. Now, I just wanted to respond to the Slido results there. You can see that current platforms are effective. We should apply a hybrid approach, is at 50%. Still a little bit more work to be done, is at 46. So on the whole, there's an acceptance that the remote platforms are here to stay, and I think that is the case. Still some views out there that it would be lovely to go back to how things were before, but my own view is that the genie is very much out of the bottle. This is going to be the way in which things are going to move forward, and the way in which we respond and develop this service is certainly going to be reflected in the successes and challenges that we experience in the future. Now, we've had a couple of questions on the Q&A. I'm going to do a summary in a second or two, but I just want to address a couple of those. There was a question about an MDT and whether it will be the norm to be online MDTs, which have proved really successful recently. We're finding that it's easier to slot them in the diary. Everyone's sort of much more available when it arranges. There's no travel time and all that sort of thing. The question poses the query, will face-to-face MDTs be frowned upon? Will it be looked at as undesirable to have these meetings face-to-face? But my own view is that the face-to-face meetings do add that extra bit that you can't get from the remote platforms. And while it may be nice to have those MDTs, maybe 3 out of 4 or 2 out of 3 remotely, I still feel that there's a place for that MDT. Certainly if the clients are attending, that opportunity to meet face to face, meet the rehab team in one room, there's a lot of value there. So if we do get the opportunity to going back to face MDTs, then I certainly feel there's a strong argument to have those face-to-face sessions. However, it's more than likely that a lot of these sessions will be done remotely. There is one more question I want to ask you all, just again, if you can respond on the Q&A bar, and that's, what do you consider the most significant influence on client engagement with remote therapy? What was that one factor that prompted your clients to engage with you and say, yeah, actually, I'm willing to try this? And I appreciate we're going to get lots of different experiences and responses to this in the Q&A bar, but I think it'd be really good for everyone to be able to look back over that bar and say, right, I can see, or oh, I hadn't considered that, or that's completely different to what we experienced, and why is that? So if you can all pop just your most significant influence on client engagement in there, when it comes to looking back at this video in the future, this webinar in the future, you'll be able to see those responses and see where the impact has been. With regards to the summary, what is the long-term impact of remote therapy? I've summarized it in a slide here. This isn't exhaustive, it's just a summary of what we've, through my chats with Susan and my reviewing of what's going out there generally. I think there is a lot to be proud of. This long-term impact is still being seen, as Susan said. It's still being developed. We now know that we can do this. So there is a lot to be proud of the developments that have been achieved over the last year. The initial findings are that we're still maintaining that client-centered approach, which for us as a firm dealing with serious injury clients is paramount, but also we know it's paramount to you too. So this making sure the client is at the center of all those decisions needs to be important. There are lots of good things, and it works very well with a large proportion of our clients, but there are also challenges and ways in which we can improve this. And I like to think of it less of a linear journey and more of a cycle. As with many treatment approaches, I think there needs to be that moment of reflection, analysis, development, application again, and then saying, okay, well, let's take this new version, let's see what we can do, and let's look at it again in 6 months. And this constant evolving cycle will help fill that evidential gap that was identified. Hopefully people will have taken it, academics will have taken it upon themselves to start looking at the nuts and bolts and the evidential gap that's there, and we will see those studies coming to the fore. At the moment, we're still in the middle of it, so as we go through that self-assessment, these little opportunities to talk amongst ourselves and engage in those groups is going to be really important. So I hope you're all able to do that across the audience there. What I want to do now is just bring your attention to a couple of forthcoming webinars. If you check out our webinar page, our library, you'll be able to see ones that have taken place, the links there. If you're more interested in the litigation, I mean, this has been remote therapy and very much a rehabilitation focused webinar. The litigation side of things will be addressed by one of my colleagues, Richard, on the 22nd of April, and he will look at the impact of COVID-19 on litigation. So the two of these hand in hand will give you a very good overview of what's happening very much from the legal side and also from the rehabilitation side, and very much work together hand in hand. So please do take a look at our pages for that. I'm just taking a look at the responses. So shared decisions, so what considers to be the most significant influence on client engagement? We've got the giving of decisions, giving the client and clinician the opportunity to make shared decisions. And again, that's that team approach, and I would like us to step into that triangle as well, and as the instructed solicitor, be there to all of us together make those approaches and decisions with regards to how the remote therapy is going to evolve. Just looking at a couple of the others. Wanting to access care and feel safe, again, paramount for everybody, but also that security that I was talking about earlier on, not only with the immediate treatment session, but also looking forwards and how that structure is going to be applied over the longer term. So all really important factors there. There's one here for you, Susan. It says, what have SP therapy services identified as the key best practice characteristics of a remote therapy session?
Thank you. Can you hear me? Thank you. We have developed our top 10 tips for a remote therapy session, and those top 10 tips will be coming out with the post webinar information. But for me, I think it's accepting it's different and establishing a new therapeutic relationship, because I think any therapy in any context without a therapeutic relationship hasn't got any value. So that's where I'd point you to if our top 10 tips are there, if they're there to help. Thank you.
Thank you, Susan. There's just one more from Sarah here. It says that she was wondering how you were keeping track of your patient's progress and how this has changed when moving to remote therapy. So was it most anecdotal feedback, or have you introduced therapeutic measures, or a mix of both?
Thank you, Sarah. Yes, I saw your question. I think as a team, we set SMART goals for all of our patients, and they have outcome measures linked to the SMART goals. One of the first questions we had to ask ourselves was, when we moved to remote therapy, was, did that SMART goal remain relevant? Because was it safe to and meaningful and realistic to actually try and deliver that SMART goal in the context of a remote therapy session? So where the answer was yes, then we could stick with the same outcome measure. Where the answer was that the SMART goal wasn't appropriate, then we had to revise the SMART goal and therefore revise the outcome measure that went with it. One of the greatest things that we actually took, we measured every single week, was actually participation, was the ability of the patient to actually participate in the session and say yes to the next session. Because in terms of meeting their needs, they always had the option. We were always very aware of either not answering the call or putting the phone down or stopping it at any way. And we did always make it very clear to them at the beginning that that was their choice. So very much in terms of whether we were winning, if that's the word to use, in terms of getting engagement with remote therapy, was did the patient participate? Were they on time? Did they agree to do it again? Because I think, as I said, we didn't come to this with a complete package. We were learning on the hoof, and we started very slow and we built things up over time. And it was really important for us that we took every patient on every step of the particular journey that we were on. So a bit long-winded, but I hope that answers your question, Sarah.
That's great. Thank you very much for that, Susan. OK, so I think we've covered the questions that are on the Q&A there. Thank you again ever so much for adding the Q&As there, and also participation in the Slido, which has given us a really good indication of how people are responding across the group to the introduction to remote therapy, and also your views on the future. And it seems very positive for remote therapy. So I just want to, it's really left to me to say thank you again. Thank you to our guest Susan, and also our team for helping with the webinar today. Please do join us again on future webinars, and I look forward to seeing you then.